So welcome to part 2 for the respiratory system lecture. Today we'll be continuing to discuss the lower respiratory system and some of the mechanisms that go with it. Picking up where we left off last time, starting with the bronchi. Alright, so these are going to be at the superior border of the fifth thoracic vertebra, and the trachea is going to be divided into a right main bronchus, also called the primary bronchus. And this is going to go into the right lung, and then the left main bronchus is going to go into the left lung. The right main bronchus is going to be more vertical. It's going to also be shorter and wider than the left. So just like the trachea, the main bronchi are going to contain these incomplete rings of cartilage that are going to be lined by ciliated pseudostratified columnar epithelium. So at the point where the trachea divides into the left and right main bronchi, there's going to be an internal ridge called the carnea, and this is going to be formed by a posterior and a somewhat inferior projection of the last tracheal cartilage. The mucous membrane of the carnea is going to be one of the most sensitive areas in the entire larynx, and this is going to be really important for triggering the cough reflex. So looking at the flow or the branching that we see in our bronchial tree, we've got quite a few layers there. So on entering the lung, the main bronchi is going to divide into smaller bronchi. These are going to be the lobular or secondary bronchi, and there's going to be one for each lobe of the lung. And just a refresher, the right lobe or the right lung is going to have 3 lobes. The left lung is going to have 2, and the difference here is due to that need for extra space for the heart. So the lobular bronchi are going to continue to branch, and they're going to form even smaller bronchi, and these are called segmental bronchi or tertiary bronchi. These are going to supply specific bronchial pulmonary segments within the lobes of the lungs. The segmental bronchi are then going to be divided even further into bronchioles. And these bronchioles are in turn going to branch repeatedly, and the smallest of these bronchioles is going to branch into even smaller tubes called terminal bronchioles. So these bronchioles are going to contain club cells or Clara cells. These are columnar, non-ciliated cells that are going to be interspersed among those epithelial cells. And these club cells may play a role in protection against any kind of harmful effects of things like inhaled toxins and carcinogens. They're also going to be really important in producing surfactant, which we'll talk more about in a minute. And these Clara cells are also going to function as a stem cell, which is going to be really important for giving rise to the various cells that are found in the epithelium. The terminal bronchioles are going to represent the end of the conducting zone of our respiratory system. So this extensive branching from the trachea through to the terminal bronchioles is going to resemble an inverted tree, and this is going to commonly be referred to as a bronchial tree. So beyond the terminal bronchioles of the bronchial tree, the branches are going to become microscopic, and these branches are called respiratory bronchioles, as well as and then also alveolar ducts. So the respiratory gases, or the respiratory pathway, from the trachea to the alveolar ducts is going to contain about 23 generations of branching. That's a lot. It's a lot of branching, and you can see how that looks kind of in these little images here. So branching from the trachea into the main bronchi are going to be called first generation branching, and then from that main bronchi into 2 lobes, that's our second generation branching, and then so on and so forth, all the way down to our alveolar ducts. So as these branches become more extensive in the bronchial tree, there are going to be several structures that can possibly change. Right? So for starters, we've got the mucous membrane that we find in the bronchial tree. This is going to change from a ciliated pseudostratified columnar epithelium to that we find in the main bronchi, as well as in the lobar and segmental bronchi. This is going to change then to a ciliated simple columnar epithelium that's going to have some goblet cells in the larger bronchioles, and then mostly ciliated simple cuboidal epithelium that is going to have no goblet cells, so it's devoid of goblet cells in these smaller bronchioles. And then it's going to further change to primarily non-ciliated simple cuboidal epithelium cells in those terminal bronchi. So you can see here the layout or the transition or the progression of the tissue and moving down the mucous membrane there and moving down that bronchial tree. So the plates of cartilage are also going to change. These are going to gradually be replaced. These are going to gradually replace those incomplete rings of cartilage that are in the main bronchi, and then they're finally going to disappear in the distal bronchioles. So as the amount of cartilage decreases, the amount of smooth muscle is also going to increase. So smooth muscles that encircle the lumen are going to be in spiral bands, and this is going to be used to help maintain patency. However, because there is not going to be any supporting cartilage, muscle spasms can result in a closing off of this air pathway. And this is going to happen during an asthma attack, and these can, if they're bad enough, be very life-threatening. So, also during exercise, things like any kind of activity that's in the sympathetic division of the autonomic nervous system, this is going to result in an increase in this activation of our sympathetic nervous system. And the adrenal medulla is also going to release hormones like epinephrine and norepinephrine. And both of these events, both the sympathetic nervous system activation and those epinephrine, norepinephrine release, is going to cause relaxation of the smooth muscles that are found in those bronchioles. And this is going to allow for the airways to dilate. So because air reaches the alveoli more quickly, lung ventilation is going to be improved. The parasympathetic division of the autonomic nervous system, as well as mediators of allergic reactions, things like histamine, are then going to have the opposite effect. And these are going to cause contraction of the bronchiolar smooth muscle. And this in turn is going to result in a constriction of the distal bronchioles. So moving from the bronchioles, then we have the lungs. These are going to be a paired cone-shaped organs that are found in the thoracic cavity. They are going to be separated from each other by the heart, as well as other structures of the mediastinum. And that is going to divide the thoracic cavity into two anatomically distinct chambers. So as a result of this, if trauma causes one lung to collapse, the other lung may still remain expanded, and this is going to allow you to continue to breathe to some degree. So that's a good thing. So like we said, these lungs are paired organs that are found in our thoracic cavity. They are going to be enclosed and protected by the pleural membrane. So the parietal pleura is going to be the outer layer, and this is going to be attached to the wall of the thoracic cavity. The visceral pleura is going to be the inner layer, and this is going to cover the actual lungs themselves. And then the pleural cavity is going to be a small potential space that's between those two layers of pleura, and this is going to contain serous lubricating fluids that's going to be secreted by those membranes. So the lungs are going to extend from the diaphragm all the way up to just slightly superior to the clavicle, and they're going to lie against the ribs anteriorly and posteriorly. The lungs are going to extend, so the broad inferior portion of the lung is called the base of the lung, and this is going to be concaved, and it's going to fit quite nicely over the convex area that we have for the diaphragm. The narrow superior portion of the lungs is going to be the apex of the lungs. We can see that up here. We've got our apex and our base. And then the surface of the lungs is lying against the ribs is called the costal surface. And this is going to match that kind of rounded curvature that we see in the ribs. So it's going to fit nice and snug within the rib cage there. Next, we have the mediastinal surface, also called the medial surface, that we see in both lungs. And this is going to contain a region called the hilum, through which the bronchi, as well as pulmonary blood vessels, lymphatic vessels, and other nerves are going to enter and exit. So these structures are going to be held together by the pleura, as well as the connective tissue, and are going to constitute the root of the lungs. So medially, then, the left lung is going to contain a concavity. This is going to be the cardiac notch, and this is going to be where the apex of the heart is going to lie. So due to the space that's occupied by the heart, like we mentioned, the left lung is going to be about 10% smaller than the right lung. And although the right lung is going to be thicker and broader, it is also going to be somewhat shorter than the left lung, and this is because the diaphragm is going to need to be higher on the right side in order to accommodate that liver. It's going to lie inferiorly to the diaphragm. So, looking at the lobes and the fissures of the lung, how we break down and sort of look a little bit more closely at the actual anatomy of the lungs. So the right lobe is going to have, the right lung is going to have 3 lobes that are separated by 2 fissures. Here we can see that down here. Our right lung with our 3 lobes and our 2 fissures. The left lung is going to have 2 lobes separated by 1 fissure as well as a depression. Right? It's also going to have a cardiac notch where the heart is going to kind of snuggle right in there. The secondary bronchi are going to give rise to the branches called the tertiary bronchi, also called the segmental bronchi. And these are going to supply segments of the lung tissue called bronchiopulmonary segments. Each of these bronchiopulmonary segments is going to consist of several small compartments called lobules, and these are going to contain lymphatics, arterioles, venules, terminal bronchioles, as well as respiratory bronchioles, alveolar ducts, alveolar sacs, and the actual alveoli themselves. So now that we've mentioned it, let's talk about those alveoli. All right, this is going to be when the conducting zone ends and at the terminal bronchi and the respiratory zone begins. So the respiratory zone is going to terminate at the alveoli. These are going to be the little air sacs that we find within the lungs. So here we can see an even further breakdown of the microscopic airway that we see with our respiratory bronchioles giving way to our alveolar ducts, into our alveolar sacs, into the actual alveoli themselves. So, the terminal dilation of an alveolar duct is going to be called the alveolar sac, and this is going to be analogous kind of to a cluster of grapes. It's going to look a lot like that. You can kind of see our little grape clusters down here in this little animation. So each alveolar sac is going to be composed of outpouching called alveoli, and these are going to be analogous to the actual individual grapes, right? So that makes sense. So the wall of each alveolus, which is singular for alveoli, is going to consist of 2 types of alveolar epithelial cells. We've got our more numerous type 1 alveolar cells. These are going to be a squamous pulmonary epithelium. These are going to be simple squamous epithelial cells that are going to form a nearly continuous lining of our alveolar wall. Then our type 2 alveolar cells are also called septal cells, and these are going to be fewer in number and are going to be found in between those type 1 alveolar cells. So, the thin type 1 alveolar cells are going to be the main site of gas exchange in the lungs, where our type 2 alveolar cells are going to be more rounded or cuboidal in shape, and are going to have free surfaces that contain microvilli. And these are the cells that are going to secrete alveolar fluid. And this is going to help to keep the surfaces between the cells and the air moist. So this is going to be included. So included in our alveolar fluid is something called a surfactant. This is a really complex mixture of phospholipids and lipoprotein, and this is going to help to lower the surface tension of the alveolar fluid. This in turn is going to reduce the tendency of the alveoli to collapse when you exhale, and is therefore going to help to maintain patency, or the openness of that airway. Also present in those little alveolar walls are alveolar macrophages. These are also called dust cells, and these are going to be phagocytic cells that are going to be responsible for removing any kind of fine dust particles or other sort of debris from that alveolar space. And there are also going to be fibroblasts present that are going to be responsible for producing reticular and elastic fibers. So underlying the layer of our type 1 alveolar cells, we've got an elastic basement membrane, and then on the outer surface of the alveoli, the lobules, arterioles, as well as the venules, are going to disperse into a network of blood capillaries, and these are going to consist of a single layer of epithelial cells and then a basement membrane. So they're quite thin. So now let's move on to the respiratory membrane. The exchange of oxygen and CO2 between the air spaces that are in the lungs as well as in the blood is going to take place by diffusing across the alveolar and capillary walls, and this is together going to form the respiratory membrane. Right? So extending from the alveolar space in the blood plasma, the respiratory membrane is going to consist of 4 layers. The first layer is going to be a layer of type 1 and type 2 alveolar cells, as well as their associated alveolar macrophages that are going to constitute the alveolar wall. Then the next layer is an epithelial basement membrane. This is going to be underlying the alveolar wall. And then third, we have a capillary basement membrane that is often going to be fused to the epithelial basement membrane. And then last but not least, we have the capillary endothelium. So blood is going to enter the lungs via the pulmonary arteries, i.e. the pulmonary circulation, and the bronchial arteries. This is also part of the systemic circulation. Blood is then going to exit via the pulmonary veins and the bronchial veins. So with this, we need to discuss ventilation and perfusion coupling. All right. So vasoconstriction in response to hypoxia is going to divert blood from poorly ventilated areas into well-ventilated areas, and this is going to allow for more efficient gas exchange. So a unique feature of the pulmonary blood vessels in all other bodily tissues. This vasoconstriction here that we have during hypoxia is going to be a unique feature of the pulmonary blood vessels. All right, in all other tissues of the body, hypoxia is going to cause dilation of blood vessels to help increase flow, but remembering it's the opposite in the pulmonary circulation. Right? So this phenomenon is known as ventilation-perfusion coupling, and this is because the perfusion or blood flow to each area of the lung is going to match the extent of ventilation to the alveoli in that area. Right? So that's what we call the kind of backwards setup that we have with the vasoconstriction during hypoxia. So here we have a nice little table summarizing the various structures of the respiratory system for your studying delights. So that basically concludes the anatomy that we have for the lower respiratory system. So now we're going to move on and start to talk about the various steps that are involved in respiration. So this is going to occur in 3 main steps. We've got pulmonary ventilation. This is going to be a mechanical step. We have our external respiration and our internal respiration, and both of these are going to involve gas exchange. Pulmonary ventilation, also known as breathing to the normal people in the world, is going to be the inhalation or inflow and the exhalation or outflow of air, and is going to involve the exchange of gas between the atmosphere and the alveoli of the lungs. So in pulmonary ventilation, the air is going to flow between the atmosphere and the alveoli of the lungs, and this is because of alternating pressure differences that are created by contraction and relaxation of those respiratory muscles. The rate of airflow and the amount of effort that you need in order to breathe efficiently are also going to be influenced by alveolar surface tension, as well as compliance of the lungs and airway resistance. So, moving forward, we're going to start by looking at pulmonary ventilation. All right, this is when airflow between the atmosphere and the alveoli of the lungs is going to occur, and this is due to alternating pressure differences that are created by contraction and relaxation of respiratory muscles. All right, this is made up of inhalation and exhalation. So, looking a little bit more closely at pulmonary ventilation and the steps that are involved with this. So we're just going to kind of go through and walk through each of these steps, and then we're going to look at a diagram that are showing a couple of diagrams to kind of explain it better. So, at rest, when the diaphragm is relaxed, alveolar pressure is going to be equal to atmospheric pressure, and there's not going to be any airflow. Then, during inhalation, the diaphragm is going to contract, and the external intercostal muscles are also going to contract. The chest cavity is going to expand, and the alveolar pressure is going to drop below atmospheric pressure. Air is going to flow into the lungs in response to that pressure gradient, and the lining and the lung volume is going to expand. So during deep inhalation, the scalene and sternocleidomastoid muscles are going to expand the chest further and are thereby going to create an even greater drop in alveolar pressure. So then during exhalation, the diaphragm is going to relax, and the intercostal muscles are also going to relax. The chest and the lungs are going to recoil, and the chest cavity is going to actively contract. The alveolar pressure is therefore going to increase above atmospheric pressure, and air is going to therefore flow out of the lungs in response to the pressure gradient. This is going to also correspond with a decrease in lung volume. So during forced exhalations, the intercostal and abdominal muscles are going to contract, thereby reducing the size of the chest cavity even further. And this creates a greater increase in alveolar pressure. So here we're looking at the muscles that are involved in inhalation and exhalation, all right? So for exhalation, we've got our intercostal muscles, the muscles that are in between those ribs, as well as the external obliques, the internal obliques, the transverse abdominis, and the rectus abdominis. Right? Muscles of inhalation are going to be the sternocleidomastoid, right? The scalene muscles, as well as the external intercostals and the diaphragm, which isn't really technically a muscle, but close enough. So we then have a little diagram looking at the positioning of the diaphragm during inhalation and exhalation. All right. So during exhalation, the diaphragm is going to move anteriorly, moving upwards, to result in a decrease in that chest cavity area. And during inhalation, it's going to move further down there. You can see like that. So we can't talk about inhalation and exhalation about pulmonary respiration without talking first about Boyle's law. So Boyle's law states that the pressure of a gas in a closed container is going to be inversely proportional to the volume of the container. This basically means that if the size of a closed container is increased, the pressure of the gas that's inside the container is going to decrease, and vice versa. If the size of our container is decreased, then the pressure inside it is then going to be increased. So this inverse relationship between pressure and volume is called Boyle's law, and we can demonstrate it like following. Yeah. So suppose you have a gas in a cylinder that has a movable piston and a pressure gauge, right? And then the initial pressure that's created by the gas molecules striking the walls of that container is going to be 1 atmosphere. So if the piston is pushed down, the gas is going to be compressed into a smaller volume. So the same number of gas molecules is going to strike the walls less often. The gauge is going to show that the pressure has doubled as that gas is compressed to half its original volume. So in other words, the same number of molecules in half the volume is going to produce twice the pressure. The opposite is also true. If you were to raise the piston to increase the volume, this would result in a decrease in pressure. Therefore, the pressure of the gas is going to vary inversely with volume. That brings us into interpleural pressure. Right? This is going to be pressure that is within the pleural cavity, and a small amount of lubricating fluid is also going to be present in this space. Interpleural pressure is always going to be negative pressure, and therefore is going to be lower than atmospheric pressure. So because the pleural cavity has a negative pressure, it's basically always going to function as a vacuum. And this is where the suction of that vacuum is going to be attached to the visceral pleura of the chest wall. Is going to attach the visceral pleura to the chest wall. Thus, if the thoracic cavity increases in size, the lungs are also going to expand. And inversely then, if the thoracic cavity decreases in size, the lungs are going to recoil or become smaller. So just before inhalation, the interpleural pressure is about 10 millimeters of mercury less than what we would see in the atmospheric pressure. So about 756 millimeters of mercury at an atmospheric pressure of 760 millimeters of mercury. So as the diaphragm and the external intercostal muscles and the overall size of our thoracic cavity increase, the volume of the pleural cavity is also going to increase. This is going to cause the interpleural pressure to decrease to that 754 millimeters of mercury. Right? So as the thoracic cavity expands, the parietal pleura that's lining the cavity is going to be pulled outward in all directions. And the visceral pleura and the lungs are also going to be pulled along with it. So there are other factors that can also impact pulmonary ventilation. Right? Surface tension is a big one. So the inwardly directed force that's in the alveoli, that must be overcome in order to expand the lungs during inspiration, is what we call surface tension. And the surfactant that we mentioned before is going to be really important in reducing surface tension. Elastic recoil is also going to be an important factor in pulmonary ventilation, and this is going to be where this is going to result in a decrease in the size of our alveoli during expiration. And then compliance is our last factor. Right, and this is going to ease with each. This compliance is the ease with which the lungs and the thoracic cavity, the thoracic wall, are able to expand. We have several other. So looking more closely at these factors that impact pulmonary ventilation. So in that lungs, we mentioned the surface tension. This is going to allow for the alveoli to assume the smallest diameter possible. So during breathing, surface tension must be overcome in order to expand the lungs during each during each inspiration. It is also going to be the major component of lung elastic recoil, and this is going to in turn act to decrease the size of the alveoli during expiration. The presence of surfactants, which as we mentioned is a phospholipid that's produced by our type 2 alveolar cells, also called septal cells, in our alveolar wall. This is going to allow for an alteration of surface tension of the alveoli, and it's going to prevent them from collapsing in on themselves following expiration. So as a result of inadequate surfactant, the alveoli of premature babies cannot necessarily remain open. And this disorder is called respiratory distress syndrome, and it's going to result in blue skin and labored breathing in the infant. This is why a lot of infants that are prematurely born are typically on oxygen, because their lungs are not fully developed yet, and they a lot of the times will typically grow out of this as those lungs finish developing. Our next factor that we mentioned was compliance, and this is going to be the ease with which the lungs and the thoracic wall are able to expand. So any condition that is going to destroy lung tissue, is going to cause it to become filled with fluid, is going to produce a deficiency in our surfactant, or in any way sort of impede lung expansion or contraction. This is going to result in a decrease in compliance. Now, last but not least, we have airway resistance. So the wall of the respiratory passageway, especially the bronchi and the bronchioles, are going to offer some resistance to normal flow of air into the lungs. And any condition that obstructs the air passageway is going to increase resistance, and therefore more pressure is going to be required to force air through those passageways. So any condition that results in a narrowing or an obstruction of the airway is going to result in an increase in resistance. So this is going to result in more pressure being required in order to maintain the same airflow. So this is a hallmark of things like asthma or chronic obstructive pulmonary disease, or COPD, as well as emphysema or chronic bronchitis. And this is going to be result in this increased airway resistance due to obstruction or collapse of the airway. So, last but not least, we need to discuss just a couple of breathing patterns and respiratory movements, and that will pretty much conclude our lecture for the day, so we're almost there. The first breathing pattern we need to talk to is eupnea. And this is normal variation in breathing and rate and depth. So this is just normal breath. We then have apnea, which is going to refer to holding of the breath. So if you have sleep apnea, this is kind of where when you're asleep, you should essentially forget to breathe or are holding your breath, you're not having eupnea, not having your normal breath rate and depth. Dyspnea is going to relate to painful or difficulty breathing. Trachepnea is going to involve a rapid breathing rate, and costal breathing requires a combination of various patterns of intercostal and extracostal muscles. And this is usually during need for increased ventilation, as with what we would see in exercise. So when you're breathing really heavy and your rib cage is kind of expanding and compressing, that's costal breathing. We then have diaphragmatic breathing, and this is the usual mode of operation to move air by contracting and relaxing the diaphragm in order to change lung volume. So then we have our we have a nice table just for your interest, looking at modified breathing movements: coughing, sneezing, singing, yawning, sobbing, crying, which apparently are two different things, as well as laughing, hiccuping, Valsalva maneuver, and pressurizing the middle ear. Those are just there sort of for your sort of information if you're curious about it. And that is all that we have on for part 2 of the respiratory lecture. So as always, if you have any questions, comments, or concerns, please feel free to contact me or ask after class. Thanks so much. See you next time.